Okay, this video is what does Rip van Winkle story have to do with psychiatry? So Rip van Winkle is written by Washington Irving. He had fallen asleep for 20 years. And then when he woke up, things had really changed a lot. So this idea of coming awake after 20 years enables one to have a relatively more objective perspective. It is kind of like the old stories about what if a Martian came from outer space, how would they see things? And the relevance here is let's talk about treatment of depression. Let's say you go back in time, the 1700s here, 1800s, and you have a young person or whatever, middle-aged person feeling very sad, as we now call depression. What would you recommend they do? Talk to their parents, talk to their siblings, talk to their friends, talk to their boyfriend, girlfriend, wife, husband, talk to the priest, read a book, take a couple days off from work. That's all reasonable stuff. Nowadays, it's pretty much take a drug, and if the drug don't work, electric shock the brain, or even now they drill a hole in the brain and they stick an electrode into the center of the brain. That's crazy, okay? And these doctors, it's because they don't know nutrition. I got a whole bunch of lectures on food and mood, the effect of food on health. There's tons and tons of neurotoxins, not tons of them, but there's a lot of neurotoxins to be aware of. You can stop all these neurotoxins from their diet and their other exposures, and that'll potentially make a significant difference. There's been experiments like Soteria where they took a whole bunch of schizophrenics and just had them live in residential housing with some counselors to, give them the little guidance they needed, and they had dramatically better results. It's called Soteria for treatment of schizophrenics. Soteria means deliverance in Greek. They had dramatically better results on a pharmacology approach to treatment of schizophrenic. And so I think what Rip van Winkle would say is have the people gone crazy. Let's take a look at the next. And oh, by the way, the drugs claim to be based on science. Yeah, right. It's checkbook science, meaning it's just paid for. Anything funded by industry almost always it just ends up being bogus. Okay. So here's where psychiatry is at nowadays. Here, let me get this picture off of here. Patient walks in, the lady checks him in here and she says, everything we do is based on science. We've got lots of treatment options. You can go down the conveyor belt number 1 for a chemical lobotomy. These drugs, most psychiatric drugs in the long run cause significant brain damage. They often cause significant brain damage in the short run, but in the long run, they're almost always bad. Okay, there's some rare exceptions to that, but psychiatry drugs are much more neurotoxic than is widely recognized. Okay, stimulants, SSRIs, okay, potential excitotoxic effects there as well. Okay, so anyways, that's a chemical lobotomy. Okay, then you can go for a surgical lobotomy like we talked about, DBS, deep brain stimulation, for treatment of depression and some other disorders. Or you can get electric shock therapy where they just randomly run electrical currents through your brain. Talk about the risk of brain damage with that. Run for your life. Now, don't get me wrong, my father was a psychiatrist and he was a good man. He did the best he could. But the pattern I've noticed in a lot of doctors is they're very conformist. Whatever they're told in the textbooks, whatever they're told in their training as a resident, they just go by it. They don't question it. And I almost think the medical education system's like a filter to, develop conformist people. And in surgery, there's not as much variety of stuff you can do. Surgical operations are relatively straightforward because I'm wondering, how did I ever get through all this stuff? Maybe because I was in, surgery where, the operations were pretty logical. There wasn't a lot of options there, okay? Now take a look at what they're doing with depressed patients nowadays. First of all, they'll try drugs that don't work well. The drugs often make the people crazy and much worse, like those SSRIs. You want to look at all the problems, that have happened with people that go into schools and do crazy things. They're almost always on these SSRIs, okay? And that's not widely talked about, but that's actually pretty well known by people who studied it. Okay, ECT, electroconvulsive therapy. They run electricity through your brain and make you have a seizure. You think that's going to make you smarter? No, that's not good for the brain, okay? It's an electrical lobotomy. Then here's the latest. Deep brain stimulation. They drill a burr hole in the skull, and then they pass these wires down into the center of the brain. Do you think that's going to improve a person's cognitive function? The other thing they don't know anything about is religion, okay? Now, there's a lot of smart people going to psychology, and I know some psychologists, and I like them. There are a lot of good people going to psychology, but I can also tell you, if you don't have Christian ethics, that makes psychology a lot better. Look at Alcoholics Anonymous. When they've got Christian ethics and, they need to replace the alcohol, a big part that played in their life with something else. And the ones that, became Christians as part of their Alcoholics Anonymous, they had dramatically better results, okay? And nowadays, if you got a conformist type person, working in psychology, psychiatry, they don't even know the difference between a man and a woman. So how are you going to go talk about your relationship with your boyfriend, girlfriend, husband, wife, when the person you're talking to doesn't know the difference between a man and a woman, okay? Come on, let's be real here, okay? Now, how about fixing a diet? You can get dramatic improvement from that. How about avoiding toxins? You can get improvement from that. How about getting some exercise, getting better sleep? They're aware of getting better sleep. Talking to friends and family, of course, I think there's some awareness of that. Religion, they're not aware of that. Study people who've recovered from depression. That's not widely done. You should look for role models and see how they did it. That's what you do for anything you want to get good at. Talking to a mentor, smart person, whatever. Yeah, you find a person good to talk to. And, some of these psychologists were pretty good at this stuff, and I like all that, Carl Rogers and all that stuff. But anyways, I think DBS is insane. Deep brain stimulation for depression is insane. Okay, here's a standard neuron. Here's a cell body where the nucleus is. When information comes in through the dendrites and it activates the neuron, it'll fire an action potential which travels down to the presynaptic terminal here, axon terminal, and these neurotransmitters, I'll show it in the next one, get released across the cleft here, synaptic cleft. Okay, here's a picture of it. This is the way neurophysiology is typically taught. All you see is signal comes in, the neuron is activated, it fires an action potential like through the sodium channels, for example, in the axon right here. These are nodes around there to speed up conduction. This causes calcium to enter into the cytoplasm of the axon terminal of the presynaptic neuron. This causes an NT for neurotransmitter. Neurotransmitter vesicles diffuse with the plasma membrane, diffuse across the synaptic cleft, bind to a receptor on the postsynaptic neuron and activate it and cause it to do something. Okay, and here's a pretty standard synapse. This would be like a synapse of a serotonin neuron, okay? I don't know if I can make myself bigger here, okay? So what you've got here is the serotonin vesicle, neurotransmitter vesicles fuse with the plasma membrane. The serotonin diffuses across the synaptic cleft. It binds a serotonin receptor on the postsynaptic neuron. This will exert an effect. And then the neurotransmitter can be retaken up into the presynaptic terminal through the serotonin reuptake transporter receptors, okay? And that's the way people sort of are taught neurotransmitter, neurophysiology. Just one neurotransmitter going to a postsynaptic neuron. But it's a lot more complicated than that. Let me just show you a dopamine neuron here. And I'll show you an example of a medication here. I got to get this picture out of the way. All right. So what you've got here is dopamine comes across, binds to a dopamine receptor. So DA is for dopamine, binds to a dopamine receptor, and that exerts an effect on the postsynaptic neuron. Okay. Then you can give an antipsychotic medication which will block some of these, let's say, type 2 dopamine receptors. Okay. So then you get less of a dopamine effect, at least initially, on the postsynaptic neuron. And again, this is standard psychology, psychiatry, pharmacology. Okay, but I'm going to show you, here's what happens in the real world. It's more complicated than that. Once you've blocked this receptor, let's say with a serotonin selective reuptake inhibitor, SSRI, serotonin selective reuptake inhibitor, the cell on the presynaptic neuron might just form more of these reuptake transporters, okay, receptors. Then it might make less serotonin neurotransmitter vesicles because it's trying to decrease this effect of the drug. So what I'm saying is the neuron is fighting the effect of the drug. It undergoes compensatory adaptations to block the initial effect of the drug. You might have, instead of having all these receptors, you might have fewer receptors on the postsynaptic neuron. All right? And even all that, what I've just shown you, still greatly underestimate what's actually going on. Here's much more accurate picture of what's really going on. There tends to be multiple neurons in the vicinity of these neurons, and there's often multiple simultaneous inputs and outputs. So you'll have GABA neurons that are inhibitory, glucocorticoid receptors, norepinephrine neurotransmitters. You can have, the astrocytes are helping out with the metabolism of the neurotransmitters. You can have a serotonin neuron in the vicinity. So it's often much more complicated than one would guess from the simple drawings. And that's why you start getting compensatory effects in all these different neurons when you put a person on a psychiatric pharmaceutical, and it's much more complicated, much more difficult to predict the effect. And so while sometimes people certainly do benefit from a drug, let's say they're having an acute psychotic episode, in the long run, the drugs tend to do much more damage than benefit. And this is part of the reason why, because the reality of the synapses inside the body in vivo is much more complicated than that pretend model of increase the transmitter, decrease the neurotransmitter that people tend to be taught. That dopamine's motivation, serotonin's happy. It's really nowhere near that simple. And that whole theory of raise the transmitter, lower the transmitter, that's actually never been proven. It's bogus. It was a marketing thing. So just so you know, these psychiatric drugs are quite dangerous, and you should be very wary of going on them, especially for any long amount of time.